We are delighted to announce a brand new BHRT protocols workshop on June 24th through the 25th in sunny San Diego. This interactive workshop, conducted by internationally known hormone experts, will teach the participant the ins and outs of prescribing female and male hormone protocols. The majority of the workshop will focus on dosing recommendations using various forms of BHRT for both men and women in all age groups. Dosing recommendations and protocols using many different patient scenarios will be discussed at length using a case history format. Tonight, I'm so excited to introduce Dr. Pamela Smith to the webinar to share her expertise in bioidentical hormone replacement therapy and dosing protocols. Dr. Pamela Smith is a diplomate of the board of the American Academy of Anti-Aging Physicians and is an internationally known speaker and author on the subject of metabolic, anti-aging, and functional medicine. She also holds a master's in public health degree along with a master's degree in metabolic and nutritional medicine. Dr. Smith is currently the director of the Center for Healthy Living and Longevity and the founder and chair of the Fellowship in Anti-Aging, Regenerative, and Functional Medicine. Dr. Smith is also the co-director of the Master's Program in Metabolic and Nutritional Medicine at the Morsani College of Medicine at the University of South Florida. Due to the very high attendance this evening, please submit your questions by using the chat option, and we will address a few questions at the end of the webinar. Dr. Smith, I'm happy to turn over the webinar to you.
Thank you so much, Lindsay. Hi, everybody. How are you doing tonight? Tonight we're going to look at some basic ideas in hormone dosing. We're going to do 3 cases, 1 female, 1 male, and 1 thyroid, because it really is all about a customized approach. First of all, when you look at dosing male hormones, it's very important to understand that men only make 4 to 8 milligrams of testosterone a day. So if we're talking about transdermal application for a male, then we really shouldn't be writing a prescription transdermally for testosterone more than 50 milligram cream. That's 50 milligram cream. I see these crazy doses of 100, 200, etc. And when you do that, when you overdose, then testosterone does not stay testosterone. It becomes E1, it becomes E2, it becomes dihydrotestosterone. High DHT increases the risk of loss of hair on the head in a male and prostate enlargement. High estrogens in a male increase the risk of heart disease and prostate cancer. Men do need estrogen, so it's important to measure E1 and E2 because they need estrogen for memory and bone structure. But again, men only make 4 to 8 milligrams of testosterone in a day. It gets absorbed very, very well transdermally, and so hence you don't have to worry about using bigger doses. The dose response curve has been figured out for this. When it comes to women, they are more complicated. This slide shows the 24-hour production rates of sex steroids in women at different stages of the menstrual cycle. And let's take an example. Let's stick with testosterone. For women, they make the most testosterone pre-ovulatory. That would be 171 micrograms. So really, the upper limit of normal that you should prescribe for testosterone transdermally for a woman would be 4 milligrams. The lowest therapeutic dose is 0.25 milligrams. So for women, the dosage should be anywhere between 0.25 milligrams and 4 milligrams testosterone applied transdermally. Let's take another one. Let's take dihydrotestosterone. Let's try DHEA. DHEA, very important hormone because it makes estrogen and testosterone. DHEA stays stable throughout the entire month, and the average dose that the patient makes is 7 milligrams. Women are very sensitive to DHEA. Men need much bigger doses. It's not uncommon to give a male 25, 50, 75 milligrams of DHEA. With women, we can start as low as 1 milligram. And it's rare we would go above 40 or even 50 milligrams, even if the patient were 100 years of age, because they do make less DHEA with age. So have to kind of know what the patient makes. Estradiol, preovulatory women make the most, 380 micrograms. Not some of these crazy doses that you see out there of things transdermally, like 16 milligrams. This is 380 micrograms. Same thing with progesterone. We all know the woman makes more progesterone mid-lutely, but again, 25 milligrams. It's also important when we look at dosing to know different conversion factors. So for example, if you're giving 20 milligrams of progesterone to a woman transdermally, then that's equal to almost 200 milligrams PO, because you need to give more PO as it passes through the liver, etc., for detoxification. I see people write 200 milligrams of progesterone, 200 milligrams of progesterone transdermally. That's a pregnancy dose, okay? So we want to make sure that we get the right dosages of progesterone, testosterone, the estrogens, DHEA, etc. When it comes to pregnenolone, then that's a different story. If you're doing testing the pregnenolone by serum, it needs to be at least 50, 50, to maintain memory. So let's say the patient is 65. Your lab may say the result is 44, and that's normal. That would be normal for someone who is in that age group, but not enough to maintain rapid fire memory. So it would be 50 is kind of the golden number for serum testing around the world. With pregnenolone, when we give it, we usually start with 10 milligrams. 10 milligrams. It's most commonly given PO. The dosage transdermally would be very similar. It's rare we go above 100 milligrams of pregnenolone. So now you kind of have your borders set so that we look in a case you have an idea of what you want to do. So let's look at case number 1. This is a 20-year-old patient with the chief complaint she does not cycle on a regular basis. Everything's unremarkable. Pretty much she is a college student. So what we want to do in younger women is to get a 28-day saliva test because her hormones flux. And so you want to look at her hormones and the changes they make throughout the menstrual cycle. If you just do a one-day test, then it may not be as representative of what happens throughout the month. And so that's one reason why I don't like serum testing for this age group. I really don't like urine testing to look at dosing. I do get urine testing for other things, but if we're talking about looking at PMS, PCOS, infertility, postpartum depression, a 28-day saliva test is the best. So this is an example of a 28-day saliva test. This first graph is melatonin. That is on the test, and the melatonin is measured in the morning, 5 p.m., and 3 a.m. with the lights off. And this happens to be a normal melatonin test, which is dead center of green. The upper box here on this slide is estradiol. That's the green. The blue in the middle is the progesterone. The patient does 11 samples throughout the month, and so the black areas that are connected by a line are the actual patient specimens. So in this first graph up there, the patient has 1 day or so they're low in estrogen, and then at the very end, and this is estradiol, she's actually high. So on average, she's pretty even. In the middle, The darker shaded area, again, is the average patient. They're supposed to ovulate around day 14 or so. Progesterone goes up, comes back down. This patient did not do that. She did not ovulate. On the bottom small little graph is testosterone. Green is the average American, North American actually. Yellow is 1 standard deviation above and below, and red is 2 standard deviations. This patient has high testosterone, 2 standard deviations above normal. So very simply, our diagnosis is right here, polycystic ovarian syndrome. So what we do need to do is an ultrasound, of course, to take a look as well, but this is a pretty classic picture. Also on this test are cortisol, which is the big box, and DHEA, the smaller box. Dead center of the greenish blue area is normal. So 2 of the specimens here are not normal. So we want to do stress reduction techniques, a multivitamin, because the adrenals need a lot of good nutrients, and adaptogenic herbs like ginseng, ashwagandha, rhodiola. The one underneath is DHEA. You want a dead center of green, which it is, and then below is the DHEA ratio, and that is good as well. So again, PCOS for this patient. So now what are we going to do? Patient has high testosterone. As we learned in Module 1, one of the best ways to deal with that is to give saw palmetto, 240 to 260 milligrams BID. If it turns out the patient's also insulin resistant, you might want to consider metformin. But she's only 20, and we did blood sugar. This is my actual patient, and her fasting blood sugar was 82. Her hemoglobin A1C was 5.4, and her fasting insulin was 6. So no problems there, so I gave her saw palmetto. Now she does need progesterone. How much do we give? Commonly in this age group, what we will give is 20 to 25 milligrams of progesterone transdermally days 14 through 25 when they're not ovulating at all, which this patient was not. So I would start at 20 to 25 milligrams of progesterone days 14 through 25. You do need to have her use another form of birth control because this will increase her fertility. And then again, for this patient, stress reduction techniques, multivitamin, and I happen to give this patient rhodiola. Now, I gave it to her BID. So to answer the question, what do you do with this patient? That's exactly what we need to do. Any questions? Lindsay?
Let's see, I don't have any questions yet. However, if anyone does, please use the chat button and we will address them in between cases. Thank you so much.
Perfect. Case number 2 is a 64-year-old male with a chief complaint that he falls asleep after dinner. Past history unremarkable. He's an auto worker. He's already on testosterone when he comes to see you, given to him by another practitioner. So he's on testosterone 17 milligram cream. He's also on DHEA 20 milligram sustained release, which is now called E4M, plus pregnenolone 50 milligrams E4M. No other complaints, and the physical examination is non-contributory. So I'm sure you've guessed by now we're going to want to look at a saliva test in this male. Could you measure it by serum? You certainly could. But you really can't dose off of serum if you're going to give the hormones transdermally. You do have to use salivary testing. So very important. I personally start with saliva testing because that way I can compare apples with apples instead of apples and oranges. But initially, could you have done serum testing? Yes. This person's already on hormones, so we're going to do saliva testing. We want to look at E2 and E1 and E2 both in males, as we did here. The E2 level is normal. The E1 level is normal. Progesterone is normal as well, but the testosterone even though the patient's on 17 milligram cream, is low. So it's always start low, go slow. So just go up in slow increments. So you can see that the normal there is quite wide in range, from 115 to 3700 as normal. Person was only at 90, so I did go to 25 milligram cream. Could I have gone to 30? I certainly could have. The DHEA is 6.8. This is not dead center of normal. I remember he was on 20 milligrams of DHEA, so I did bump him up to 30. If this had been a woman, I would have done a smaller bump up. Cortisol is normal except for, as you can see, in the evening. And I really like and suggest to you to get these 4-point cortisols, where you actually get one at 8 in the morning, 12 p.m., 4 to 5 p.m., and 11 p.m. And the reason for that is you can really see what is going on. And here, if you sit down and talk to him, as I did with this patient, we discovered that with him, his big time stress was trying to pick up his kids after work before, or grandkids after work before daycare closed. And it closed at 6, and after that, every 5 minutes, there was an additional fee. So he was the grandpa assigned to pick up the kids, and problematic for him, and that was causing stress. Okay? So in review as to what we're going to do with this patient, we're going to increase his testosterone from 17 to 25 milligrams. We're going to increase his DHEA from 20 to 30 milligrams. And then we're going to help him with stress reduction techniques, perhaps even calming herbs like chamomile and lemon balm, adaptogenic herbs, and a multivitamin. And actually, this patient did very, very well. Questions?
Hi, Dr. Smith. I do have a question. What does E4M mean?
E4M is the new nomenclature for sustained release. Sustained release, technically in the United States, can only be used by medications and the process that they use for sustained release if they're made by pharmaceutical companies. A little different technique here when it's compounded. So they've now given a new designation, which is E4M. Has a long explanation as to what it stands for. Not important, just E4M.
Okay. Bear with me for one quick moment. Dr. Smith, this is relating back to the first case.
Sure.
My apologies. This is regarding the dosage for the saw palmetto. What was your dose that you used of saw palmetto?
Saw palmetto, 240 to 260 milligrams BID. That's also the same dose you would use if the dihydrotestosterone level were high and you wanted to bring it to normal so the person didn't lose hair, for example.
Okay, this is relating to the case you just presented. Does everyone need pregnenolone?
That's a great question. All of these are great questions. Certainly someone who's 40 and above, I always give pregnenolone because it declines with age. If someone is very, very stressed younger, then yes, I do get pregnenolone because the body will do something called pregnenolone steal. What it will do at somebody, even if they're 24, it will take their pregnenolone and it will almost exclusively make cortisol if the patient is really, really stressed. And the reason for that is, as you all know, you need cortisol to live. Your body stops making cortisol, you die in 7 days. So the body will preferentially make cortisol above any of the other hormones in the steroidogenic pathway. So let's say they were 24 and they had some real catastrophes in their life for a couple of years, it just never stopped, then I might get a pregnenolone level, but I don't always give pregnenolone in that age group if they have a normal pituitary. I usually go after the cause of the problem, which is stress.
Okay, Dr. Smith, this is relating to the first case, but when do you retest the patient?
Great question. What we do, and what I'd like to suggest to you, is bring the patient in, interview them, etc., decide what to order, bring them back, go over the test results, and then if you're starting them on hormones, they should be rechecked in 90 days. That's for men or women. Then every 6 months thereafter.
Okay, and the last question, what if testosterone levels do not rise in spite of higher dose? What would you do?
Actually, they will. The only time you see it not rise is when you're using serum. Because if you're using serum and the testosterone was applied transdermally, it goes into the red blood cell, stays for 3 seconds, and then it's gone. So you'll never measure it. The other problem could be is that the patient's not rubbing it in. You only need to rub it in, honestly, for 1 minute, but I always tell my patients 2 minutes so that they rub it in long enough. It should be applied to an area where there's no hair. So women, commonly, we put it on the thigh, rub in for 2 minutes, and rotate sites. If she applies it to the same location all the time, then she will grow hair there. She's not going to be happy about it. For a male, we suggest the inner thigh because it has less hair, and the hair has actually been rubbed off by the pant seam, or we suggest the top of the foot. You could put it in other locations, but you do have to worry about transference, so that you want to make sure that the patient is not transferring it to their spouse or other loved one, and that includes children, grandchildren, and even animals. And lastly, case number 3. This is a 34-year-old female with a long history of hypothyroidism. She's come to see you because she's taking Thyroid and has heard that Armour Thyroid may be better for her to lose weight. The remainder of the history is unremarkable, including the fact that she states she does not have any stress, although she admits to taking antacids on a daily basis. And you can see her weight, height, and BMI, so obviously she's overweight. So what do we want to do with this patient? I did do a 28-day saliva test on this patient just to see where she's at, because she was only 34, and it was entirely normal. So this was not a stress issue, or it was not an imbalance of the female hormones. So we did do thyroid. Optimal TSH level is the lowest limit of normal to 2, if you're reading the anti-aging literature. If you're endocrinological literature, then it's 2.5. This person's TSH was high at 9.49, and you can see their T4 is low and their T3 is normal. Reverse T3 was normal, but the patient had positive thyroid antibodies. Now this was my actual case. I put the patient on Armour Thyroid. I would not do that now because other studies have come out showing that if the patient has an autoimmune process, what we want to actually do with them is to use non-porcine. I would do iodine testing now before I put the patient on hormones. You'll see that I did do iodine testing eventually in this patient. It wasn't available when I first saw them. So I would do iodine testing first and then look at what we want to do. And most patients would do better with T3 and T4, although certainly I could have given levothyroxine or Synthroid because it was the T4 level that was low. But with a TSH that high, that's probably not going to work. Okay? So the person got 30 of Armour. Lab studies, well, we got some improvement, still positive thyroid antibodies. When that happens, make sure you take the patient off of gluten and fix their gut. We increase the Armour to 45. Well, here we're pretty good, except for we have a little too much T3 in relationship to T4. Armour Thyroid, Nature Thyroid, West Thyroid, all of those are very close to 4 parts T4 to 1 part T3. That ratio may not be perfect for every single patient. So what I did is I took here Armour Thyroid, and I'm going to show you a graph at the end. Armour Thyroid, 45, how much T3 is that? How much T4 is that? And I back down on the component of the T3 and increase the T4 component just a speckle, repeat levels in 6 weeks. Oh dear, worse. Okay, so I did it again. At that time, iodine testing came out. Her levels were low and she was placed on iodine iodide, which was iodoral, 1 a day, which was 12.5 milligrams. Well, here we are, not so great. Oh my gosh, this is worse. So at that point in time, we figured there was a problem, okay, either with how the thyroid was being made or the patient. So you have the right when something is compounded to send it out for certificate of analysis. I did, and it was very accurate. The pharmacist made it right, so it meant the problem was with the patient. And it turned out to be a gut problem. So when the patient's gut's not healthy, you don't want to give sustained release initially or E4M. You want to give immediate release until you fix the gut. So you want to remove the allergens, medications, etc., that may be a problem that you can remove, replace, repopulate, and restore the gut with things like glutamine, etc. So this person in the middle of doing the 4-hour program, I recompounded it again, not sustained release, not bad. But now we finished fixing the gut and a little bit too much thyroid medicine. So we backed off on that, recalculated again. We're getting closer. At this point in time, the gut was healthy, so I changed her to sustained release, and there we are. Thyroid antibodies were better, and this is before we knew to take them off of gluten. You had taken this patient off of gluten, they would have done really well, and you can see the numbers are perfect. The TSH is right in the right range, and the T3 and T4 are dead center of normal, which is what we want to see. Now, this is the thyroid dosing conversion chart. So you can see that Armour Thyroid 45 milligrams is equal to T4 28.5 micrograms and T3 6.75. So that's how I went back and I increased the T4 just slightly and decreased the T3 when I put the person initially on compounding. And that's how I did it. Now, it's very exciting because for the first time ever anywhere by anyone, we are going to be doing an actual entire seminar on how you write prescriptions for compounded thyroid. There's a lot of great graphs that I've been developing with the help of my physician's assistant, Savea Wickstrand, and they're going to be like this. This is hormone writing for the dummies because it's really easy. This is what it is. You can see it's all printed out here. We're going to have other examples where you see my actual calculations. So this will be the first time ever anything like this has ever been given. And that is going to be at the advanced protocol dosing for hormones. So it's going to be protocols for dosing men, protocols for dosing women, and it's also going to be very exciting on thyroid. It's a workshop. It's only 2 days, June 24th through 25th. Absolutely fabulous. I'm really, really excited in San Diego. It's a beautiful property. I've stayed there a couple of times now. And 2 days, it's not an expensive workshop. And I really encourage all of you to come because I've now looked at 20,000 saliva tests. And I always said there are no protocols, but you know what? We need a place to start. So mathematically, I've gone back and figured out protocols for male and female hormones after looking at 20,000 saliva tests. So you'll be given the protocols to do that. We will have numerous case histories we're going through. Dr. Gary Huber, who is one of our top-rated speakers and an internationally known hormone expert, will be showing us his tricks to the trade. What do you do on Monday morning when it comes to dosing? And Dr. Philomena Trindade, which literally is internationally known, absolutely, because she has a practice in both the United States and a practice in the Azores. So she teaches in Europe and practices in Europe, along with being a major professor for us here in the fellowship. And the three of us will be doing this advanced protocol workshop. So I really, 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 really I think this is going to be my favorite ever. Hope that you all will join us in San Diego, June 24th through 25th. So really, when we looked at these three cases, a customized approach for hormone dosing is achievable for all patients, whether it's sex hormones or thyroid, their placement, it really is about optimal care. Any final questions?
Yes, we do have a few, Dr. Smith. A question about the iodine testing. Is the iodine testing serum?
It is not. It's urine. That's the way it's most commonly done worldwide. I think you can get it as serum, but it's not as well accepted.
Okay. How often do you check the thyroid antibodies?
Well, first of all, let's say, how long do we check thyroid? I check thyroid every 6 months, but it also should be checked every time you change the dose. So each of those times I changed the dose, you saw that I measured thyroid. And that's absolutely required anywhere in the world by everyone's medical boards. So you measure it, you give a dose, we measure it in 6 weeks. Anytime you have a dosage change, we measure it in 6 weeks, and then every 6 months. Now when it comes to measuring thyroid antibodies, if the patients were negative, then I usually measure it every 2 to 3 years if they're on thyroid medication or if they have symptoms of hypothyroidism. If their antibodies are positive, then I usually do measure them at 6 months intervals initially and then yearly.
Okay, this is fantastic. Dr. Smith, we want to be mindful of everyone's time. To be honest, I've never seen so many questions coming through. I think this workshop is really going to be very engaging for the participants. One last question. For the people who have attended Module 1 in the past, can you comment on how this will really complement their learning?
Oh, absolutely. Module 1 is, the basics. This is, you have to know the biochemistry and physiology of the body in order to know how to dose. So it's the basics. You have to take Module 1 first before you do the workshop. You won't get a lot out of it if you don't, because you need to know the actual basics. What are the 3 estrogens? What do they do in the body? What is progesterone, testosterone, DHEA, cortisol, thyroid? It's a hormonal symphony, as is insulin, as is pregnenolone. And so in Module 1, we teach you really the biochemistry, physiology. We do give you case histories and great examples, but there's not enough time in Module 1 to then go back and reteach a whole protocol. So what we suggest to everybody, Module 1 is a must first, then come take the workshop so that you'll have the exact thing that this is what you do on Monday morning.
This is great. For those who did not have their question answered, we will address it by email. This will lead me into a very special offer that we're offering our webinar attendees tonight. For those of you who have not done Module 1, you have an opportunity in May at the World Congress to join us live, participate with the faculty, really build your therapeutic toolbox, or you have an opportunity to do it online. And for that, we are putting together a package where you can do Module 1 and a workshop, and you will save over $1,000. For those of you who have completed Module 1, we do have this special rate of the workshop for you that will save you up to $500. Please give me a call tonight. The space for this workshop is very limited. My direct line is 561-777-6807. That's 561-777-6807. I'm certainly here to reserve spots this evening. Dr. Smith, thank you so much. Definitely always appreciate your time and your expertise. Any final comments?
No, thank you so much, Lindsay. I just want to reiterate to everybody that when you walk away from Module 1 and the workshop as a combo, that really this is what you do on Monday morning. People always say, well, how do you do it? This is the combo everybody should take so if they want to be a world expert in prescribing hormones of all varieties. Thanks so much, Lindsay.
Thank you so much, Dr. Smith, and thank you everyone for attending this evening.